Chapter 58 Adult and Pediatric Emergency Drugs. Oxygen. This is going to be one of your most important drugs in an emergency. May have both beneficial and adverse effects, and it's used to promote that optimal airway and breathing before the administering any other pharmacologic agents. You want to maintain that oxygenation between 94 and 99%. And this is going to be used in cases of hypoxemia due to physiologic stress, or oxygen delivery devices, with choices everything from a non-rebreather at 15 liters per minute, or if we just need a smaller bit of supplementation, we can go with a smaller nasal cannula. One thing to keep in mind is that high oxygen concentration in COPD may cause a loss of hypoxic respiratory drive. And by that, I mean in a normal, healthy person, you don't get your stimulus to breathe from low levels of oxygen. You get that stimulus to breathe when high levels of carbon dioxide. But in the case of COPD patients, they always have that high level of carbon dioxide. So they're falling back on that low level of oxygen to get their stimulus to breathe. And unfortunately, when we give them high levels of concentrated oxygen, that can wipe out that drive so that they're not getting that normal stimulus to breathe that you and me would. In the case of cardiac emergencies, there's going to be a handy acronym we're going to teach is MONA, morphine, oxygen, nitroglycerin, and aspirin. The aspirin is going to be there as an antiplatelet. We don't want that clot to grow. And in the case of nitroglycerin is going to be given as a vasodilator. We want to open up that coronary as much as we can to get as much blood flow through as possible. Morphine. It is a small vasodilator as well, but our primary purpose here is going to be the pain. An MI hurts. That chest pain can be severe. And when that patient's in pain, what happens? The body's stressed and it's demanding more oxygen. And by wiping out that pain, by removing that pain, we're lessening the oxygen demand from the heart. Atropine. This is going to be used in case of severe bradycardia. These treat the hemodynamically significant bradycardia and even some types of heart blocks. They administer 1 milligram IV Q 3 to 5 minutes until that desired heart rate is achieved, or we've given the maximum of 3 milligrams. Adenosine. This is going to be used in cases of supraventricular tachycardia, SVT. The part is pumping so fast it's out of control. And it's the pharmacologic equivalent of turning your computer off and turning it back on again. It slows the impulse conduction through the heart's AV node and restores a normal rhythm. We're actually stopping that heart for a second, giving it a pause to hopefully reset into a more productive rhythm. Diltiazem. This is a second-line agent after adenosine to treat SVT. It slows the ventricular response rate in AFib or flutter. Amiodarone. This is a ventricular antidysrhythmic. And it's a first-line agent in ACLS algorithms for treating those life-threatening ventricular dysrhythmias, particularly VFib and VTAC. And we're going to get much more in-depth with these dysrhythmias next term in MedSurg. Lidocaine. This is another ventricular dysrhythmic, and it was given for a long, long time, and it's still given, though amiodarone has kind of taken its place as the first choice. Procainamide. This treats ventricular tachycardia, PVCs, and other rapid supraventricular tachycardias that are unresponsive to adenosine. Magnesium sulfate. This treats refractory ventricular tachycardia or VFib, and especially in things like torsades de points. This magnesium is going to be one of our first choices to help correct this conduction irregularity. Epinephrine. This treats profound bradycardia and hypotension. Also used in things like asystole. Think of it like adrenaline is giving that heart a jolt to try to get it back working and moving again. Sodium bicarbonate. This is used to treat severe metabolic acidosis, hyperkalemia, and can also be used to specific drug overdose situations, such as a patient's overdosed on aspirin, salicylic acid. As we discussed in our diuretics chapter, one of our drug of choice for intracranial hypertension is going to be mannitol. This is an osmotic diuretic that's going to be used to remove that fluid and try to reduce that pressure within the cranium. Naloxone. If any of you are paramedics out there, you are very familiar with this drug. This is your opioid antidote, and it is extremely effective. It works very quickly to reduce the effect of opioids. Flumazenil, Romazicon. This is the reversal agent for benzodiazepines. In the case of toxins, we may use activated charcoal. This presents the absorption of toxins in the body if that substance is known to be affected by charcoal. It can be given as a slurry or through a gastric tube, ideally within 30 to 60 minutes of ingestion. Dopamine. This treats hypotensive shock states and works to increase the heart rate and bradycardia when unresponsive to atropine. Dobutamine. This is used in cases of shock to improve cardiac output. Norepinephrine. This is a potent vasoconstrictor, again, used in shock to rapidly pick that blood pressure back up, get the body perfusing itself again. Epinephrine. We've talked about it in our cardiac sense, but it's also a drug of choice for anaphylactic shock, acute and severe asthma attacks. And you want to use it carefully. You want to monitor closely for tachycardia, dysrhythmias, but it's going to come on very quickly. Again, it's adrenaline. Albuterol. This is that drug that opens up that airway. We got an allergic reaction. We have COPD, emphysema. This patient cannot get air. Our first go-to drug is going to be albuterol. This is going to be the first drug we give. We want to open up that airway as quickly as possible. Diphenhydramine, Benadryl. This is an antihistamine administered along with epinephrine to help treat that anaphylactic shock. Dextrose 50%, D50. This is going to be our go-to in cases of critically low hypoglycemia, critically low blood sugar, such as the patient's had a dangerous amount of insulin. We want to get that blood sugar back up quickly as possible to keep them alive. Glucagon. This is going to be another emergency med we can use to rapidly pick up that blood sugar. It stimulates the liver to release its stored glucose and rapidly get that blood sugar back up there. Hypertensive crisis. This is at critically high blood pressure. And one thing to keep in mind is we don't want to rapidly drop it. We want to bring the blood pressure down 20% and gradually bring that blood pressure down to where it needs to be. One of our drugs of choice for a hypertensive crisis is going to be labetalol. This lowers the heart rate, blood pressure, along with myocardial contractility, as well as lowering that myocardial oxygen consumption. It also reduces vasoconstriction, resulting in that sympathetic nerve system stimulation to further lower that blood pressure. Nitroprusside. This is going to be another nitro derivative, and it's a major vasodilator again. We want to expand out that blood vessels and lower that blood pressure. Furosemide, another drug we covered very deeply in our diuretics chapter. Again, this is a loop diuretic, and it promotes that renal excretion of water and sodium, but it's also flushing out a lot of electrolytes, particularly potassium. For our first practice question, a patient presents to the emergency department with severe respiratory distress, hives, and edema after being stung on the face by a bee. Which are the accurate nursing assessments of the situation? That be A, hypotension and bronchospasm will progress rapidly if treatment is delayed. B, the patient is suffering from anaphylactic shock. C, epinephrine and diphenhydramine are the drugs of choice as first-line agents. Or D, prompt treatment with drug therapy will prevent this syndrome from occurring again. That answers are going to be A, B, and C. Hypotension and bronchospasm will progress rapidly. The patient is suffering from anaphylactic shock. And epinephrine and diphenhydramine are going to be our go-to drugs of choice to help reduce that swelling, open that airway back up. For our second question, which patient finding indicates that the administration of glucagon has been effective? That be A, an improvement in level of consciousness, B, an elevation in respiratory rate, C, a suppression of heart rate, or D, a reduction of blood pressure. And that answer is going to be A, an improvement in level of consciousness. And for our final question, a patient is experiencing both atrial and ventricular dysrhythmias. The nurse anticipates the administration of which medication? That be A, adenosine, B, amiodarone, C, atropine, or D, epinephrine? And that answer is going to be B, amiodarone. But anyway, that's all we got for this chapter. I'll see you in the next slides.